This is a study that we were looking at with older patients who don't do so well with traditional chemotherapy for ALL. Although we've made vast strides in young patients with ALL, particularly using pediatric-inspired regimens, older patients don't tolerate intensive chemotherapy that's required to cure them very well. And there's a number of novel therapies that are coming through that we've heard a lot about actually already at this meeting. One being Blinatumomab, which has been used successfully in relapsed ALL and treatment of minimal residual disease. Inotuzumab being another one. So this is a CD22 directed antibody drug conjugate. It carries an alkylating agent into the cell that causes DNA damage, and the CD22 gives some targeted properties to it. It was initially used in relapsed ALL with quite a lot of success, and so what we've done is we've actually dramatically reduced the amount of chemotherapy that we're giving. The regimen is kind of based on hyper-CVAD, but there's no anthracycline, which is poorly tolerated by older patients. Cyclophosphamide doses are reduced 50%, methotrexate dose reduced 75%, and cytarabine 83%. So they're getting really small doses of chemotherapy combined with the inotuzumab, and actually very high rates of complete remission and MRD negativity, so quite impressive results. And compared to our historical patients in this age group, much improved progression-free survival, the median not reached at 3 years of follow-up. The major problem that we've seen with the treatment is veno-occlusive disease of the liver. This is kind of a unique toxicity with inotuzumab ozogamicin. It was seen initially when the drug was used prior to allogeneic stem cell transplantation, and particularly when patients receive busulfan and drugs like that as a conditioning regimen, which is not a kind of consideration so much with the age group that we're using this treatment in. But we did see a number of cases of VOD in the absence of transplantation. So actually during the study we amended the protocol to reduce the dose of the inotuzumab to try and ameliorate that problem. But I think it's actually a really exciting time in the treatment of ALL. I think going forward what we're going to be doing is probably giving even smaller doses of chemotherapy combined with inotuzumab, and adding in other novel agents like blinatumomab, so that we can kind of spread the toxicity and maximize the efficacy.